Good afternoon, everyone. Thank you so much first to Future Care Capital for hosting this event, and hello to all of the social care data enthusiasts of every kind and shape all dialed in. I'm really thrilled to welcome you to this event. We have a really wonderful lineup of individuals ready to speak about social care data analytics to you. My name is Ellen Coughlin, and I work at the Health Foundation, managing different programs seeking to improve and advance the way that we use data analytics across health and care in the UK. For those of you that aren't familiar with the work that we do at the Foundation, we are an independent charity committed to bringing about better health and care for everyone in the United Kingdom. The data analytics team, which is where I work, we contribute to that in a few different ways. So whether that's funding teams in the health and care system to test and develop different analytics tools, or performing in-house analyses, which I don't do, but my talented colleagues do. And this afternoon, we will hear from first from each of the project leads from the Strengthening Social Care Analytics Funding Programme, which awarded funding to 5 different projects with the aim of testing different ways to use data better in the social care system. You'll have the opportunity to ask some questions, and then we'll hear from SQW, who were our evaluators of the programme, and they have some reflections and recommendations for you. Later, we'll hear from Raj Mali at the Department for Health and Social Care, who will talk about the social care data strategy vision. And then finally, we'll hear from Peter Bloomfield from Future Care Capital about their work. But first thing first, I'll just give you some context for the projects and the funding programme that we're about to hear from. We set this funding up, or this funding programme up, a couple of years ago now in the wake of the pandemic, when it really became clear that this lack of actionable intelligence in social care was not only hindering efforts to address the pandemic and protect those giving and receiving care, but perhaps also in a way obscuring how terrible the impact was, at least in the short term. So through a number of different workshops with people from all across the country, whether they were caregivers, people in receipt of care, their loved ones, care providers, care commissioners, voluntary organisations, and basically anyone that I could email or call at who had time. All together, we determined 3 priorities for funding. And the awards that we ended up funding, which you'll hear from in a moment, used social care analytics to either create a safe and resilient workforce, or to address the poorest outcomes, or to better reflect lived experience. So each of those project leads are going to describe their journey working towards those aims. Sadly, Matter Community, one of those projects, a care provider in the Southwest, couldn't be here. So instead, I will be running through what they aimed to do and how you can find out a little bit more. So really, without further ado, I'd like to welcome Equal Care Co-op to the stage.
Hello, everybody. And thank you very much for being here. To echo Ellen, we are really looking forward to sharing with you the year and the journey through the Social Care Data Analytics project. I am just going to share my screen. Okay, so I will be co-presenting this with project partners Open Data Services. I think I can, yeah. Here we go. Simon, who will be coming in to explain a few of the slides, including the more technical elements of the project. But to set the scene, this is the title of the project that we ran, Open Tendering and Open Performance. And that relates fundamentally to the idea that social care data and information, both in relation to the tendering practices, tendering outcomes, and then also the resultant performance of those services, for which a huge amount of public money gets spent every year, is largely happens in the dark. So here's just a little representation of a standard block contract. It gets procured by commissioners. There is usually some level of service user involvement, which it tends to be called. It's subject to very long tender specifications, very tight deadlines, and then it goes out to tender. Organisations compete. nobody sees the winning tender, nobody really sees the specification either, and perhaps with the exception of some learning disability contracts in the most enlightened of councils, there is no attempt made to make those specifications more accessible to the community that it is supposed to be serving. So overall, everybody is pretty much in the dark, and that doesn't just relate to people who are getting care and support or giving care and support, of whom we think they are the most important, in fact, the only people that we should be concentrating on in this system. But social work teams, care and support providers themselves, commissioners, councils, policymakers and central government bodies have got very little insight and to some extent oversight about what goes on within and across the system. So as a result, the decision makers in practice as to how those services get implemented, get run, get designed, get commissioned, get ended, are sat with these two groups. There is the procurement officers commissioning team in the council, occasionally with the representation there, and then the service manager or ops area managers of the provider, business development team and senior management. Nobody else really gets a look in. So we started this project with a few principles. One is that social care tendering should be fundamentally accountable to the people who give and receive in those services, that it should be open and transparent to our communities, and that it should be very easy to surface what works and what doesn't, so that we don't keep repeating the same old mistakes and spending the same amount of money on things that don't work. Easy to say. Simon, would you like to jump in with a description of the project itself? Is he there?
I'm here.
Yeah, great.
Did you want me to talk to the trust and culture building?
Yeah, go for it.
So that brought the project participants together, and we did quite a lot of work initially around how we would set up the participatory design workshops and exploring the concept as stated there about information as power. And there was a lot of work that was done. So there were 4 participatory design workshops. 3 of them were with people who were giving and receiving care and also family members, and then the 4th workshop was with commissioners of social care, domiciliary care. And based on the results that we had from that, we used those results to focus on 2 technical design sprints, and these integrated the project outcomes and the results from the workshops, which were fairly high level, and we used the open contracting data standard as a means of publishing data relating to the contracts. So currently in the UK, if you want to find out where any information about a contract or about a tender in essence, then you would go to somewhere like Contracts Finder or Find a Tender Service, and this is where local authority tenders are typically published, and the standardization of data is using the open contracting standard. But Contracts Finder, as Emma's pointed out, it only really publishes tenders and potentially awards, and it's not possible to track down the progress of a contract in a friendly way. I mean, you can download the monthly spending data reports from a local authority and try to figure out what's been paid out against the contract, but it doesn't really help you get an overview of what's actually happening as a result of the tender being awarded and the contract running. So the 2 pieces of software that we built during apples and oranges was a tool we call OCDS Editions, which supports a third party such as Equal Care Co-op to create structured data that augments existing open contracting publications, such as those on Contract Finder and Find a Tender Service. And then we have another one, which is OCDS Metrics Analysis, and this is a tool that's used for creating and querying metrics data, and that enables Equal Care to publish structured data either as a whole co-op or at a contract level about their performance. And finally, moving to implementation and review, we developed some analysis of that pilot data set using 2 Colab notebooks. And the first notebook actually builds the data. It builds it into what's called a data cube, and that's from Equal Care's survey results from their survey of people who give and receive care. And the second analyzes that data, and we'll see some of that later. Emma, I'm happy to hand back to you.
Thank you. Okay, so just a few pictures from the workshops. You can read a little bit more about how experiences that workshop participants had on our website, which is blog.equalcare.coop. And we used a technique called rich picture mapping, which was essentially the idea that you can sit down and describe a system, looking at it through its objects, so its structures, its processes, and its tensions. The outcomes of we started with a couple of questions. How do you buy care for an individual, and how do you buy care when you are faced with doing it for a group of people? So really putting ourselves in commissioners' shoes, and having a go at unpicking that very knotty problem. The emergence from the 4 workshops was quite varied, and some of it extremely unexpected, but entirely in keeping with the ethos of the project. So we published a full report entitled Buying Our Care, which emerged from the participants, the experiences of the participants in each of the workshops, and which is available, will be available after this presentation. And then, as Simon was saying, we also used this to create the beginnings of a structured data model that could be used and applied to the evaluation of contract performance, and also to be published for the organization as a whole. One of the most I guess there's a picture of the report there, the published version. One of the interesting emergences of this was what we're calling Workshop 3, which was conducted entirely in a mixture of Punjabi and English. And it was Muslim women living in Calderdale who had some experience of social care system, usually through children and their relatives. So there was something that started to emerge in this workshop, which I think, going back to the fundamental goal of transparency in social care, simply the power of providing a space to listen, has drawn out themes that were kind of, in many cases, very upsetting, but which also sort of demonstrated that there might be a pattern here. So that workshop prompted this meeting that you can see here. It's actually started slightly unexpectedly, but independent scrutiny panel at the council, some attention from councillors, and then also, and most importantly, a user group, essentially, of Muslim women, predominantly called Nur-i-Sabil, which means Path of Light, and which is dedicated to empowering the local community in Calderdale and redressing some of the systemic imbalances that they came together in the workshop to talk about. So from there to the data itself, which, although slightly dry, I think has no less potential political impact if it is taken, if its potential could be realised. Over to you, Simon.
Thanks, Emma. So this is a snippet from one of the Colab notebooks, and what they do is they mix the code with the presentation, with the graph. So you can, so we've included all of it here. So you see how we're creating how we're displaying the graph, and then the graph below. So has your well-being changed as a result of involvement with Equal Care? And here, of the, I think there were 17 or 18 people who'd responded, 16 or 17 had said yes, and 2 had said no. So that makes 19 who responded to this particular question. So here, first of all, OCDS Editions interacts with Contracts Finder. It links back up to the original publication. And then here we see how the Equal Care metrics block, which creates the data, is being used here to create a graph. And I'll move on to the next.
Oh yeah, just sorry, a clarification on that question. It has your well-being changed as a result of their involvement, because it's asked of the relatives of people receiving support. So that was relatives responding to that question, as opposed to people receiving care. But yeah.
Thanks for the clarification. You'll notice I skipped past there because I wasn't entirely certain what was going on with those. So no, that's fine. I'm fine with this. So then this is an example of another question where we're able to, because people give some of their personal data when they fill in the survey, they give their age within a range, they give their gender, and they give their ethnicity. And here we can see, so when asked whether they know who is in their team, everybody said yes for a start. And then we're able to split that out and demonstrate it over different age ranges. So this, we can do that against gender and against ethnicity as well.
Yeah, so the what we kind of want to point towards here, yes, here we go, right, transparency of connections. Exactly.
So the connections that we use, so we publish a unique identifier for Equal Care Co-op. Equal Care Co-op are registered with the FCA, so we identify them using structured data by the scheme and by their registration with that scheme. That means that Equal Care Co-op are globally identifiable when they publish in a recognised manner, because we use OrgID, which is an open source, open data project that maps registers around the world. We use the OCID, that's the Open Contracting Identifier, to link Equal Care Co-op's publication to the data on Contract Finder. So that's what I mean when we say we're augmenting it. And that links it to existing data that's already been published. And then we publish metrics against SWEMWebs and the patient-doctor depth of relationship scale, which is which are the survey questions, some of which you've seen. All of these together make our data findable, comparable, and reusable. One other thing I'd add just before we finish, before I hand back over to Emma, is everything that we've published is open source. Now, there's a fairly high technical barrier to usage, but within the open contracting data standard community, there are plenty of people who can pick up and reuse the OCDS Editions and the metrics block tooling, and any survey that is structured in a similar way to the one that Equal Care Co-op published can be used. It isn't specific to the survey. So if Equal Care Co-op chose different questions in a future survey, the tooling is already set up to support that.
Yes, thank you. So yeah, just for those, SWEMWebs is the short version of the Warwick Edinburgh Mental Wellbeing Scale, which is a wellbeing measure that is fairly universally applied in health and social care services. So why is all of this important? Why is this project relevant? And I guess, yeah, what are the pointers for how could we take this work and expand upon it and develop on it for the future? So one of the benefits that we've started to see just from this pilot or prototype really is that this offers a potential breakout route, so that we've got potential comparisons, which is impossible at the moment, between local authorities, organisations themselves, organisation types and locations and spread, size, etc., contracts and service types. So there's a huge amount of research input expended on the ability of certain types of services to achieve certain types of outcomes, but there is no universal data set to be able to truly understand that those potential impacts at a much wider scale than one-off research projects. So this does have the potential to offer a huge amount to the social care and health community if this project could be expanded on. The unique identifier that Simon mentioned does also allows us to increase the quality of the data, as that really helps support the comparison features. And although some of the performance data and performance information may or may not be what organizations want to keep private or not, if we can move towards a much more sort of open ethos in amongst this sector, then it can only be of benefit to the people that it is supposed to be serving. Another key thing that we found is that there's real flexibility here. So although we have chosen to use standardized tools to measure these things, we can also choose to ask those questions about what matters to us. So for example, at Equal Care, we measure something called team turnover, and that is the extent to which anybody receiving care and support has support from different individuals. So their team, the numbers of people in their team that they see day to day. A normal domiciliary care agencies don't measure that. That's just not something that's on the radar to measure. But the numbers are very high. People will usually see 30 to 40 people a week. One of the things that we like about our model is that people generally only see between one and 5 or 6. But that's something that we need to measure because that's what matters to us. And then again, kind of looking back to the development of and the emergence of Nwy Sabil, of the work that Calderdale Council is doing in response to that, response to those stories. So there's the value of transparency at all levels, even when it is uncomfortable. So political, technical, experiential in terms of the work and the emotional labour done across all members of the social care sector, and across very diverse stakeholders, from commissioners through to care workers through to people receiving support. Thank you very much for listening.
Yes, thank you.
Thank you, Emma. That was wonderful. I think that's such a radical use of data, and it's really exciting to see where you'll go next. I'd like to welcome now Royal Mencap Society to speak to us about their project.
Hello there. So my name's Owen, and I'm going to be talking about the use of data analytics with regard to quality of life. So let's start at the beginning. What is quality of life, and what is the personal outcome scale? So a good quality of life is something we all want. There's nothing different from anybody in any strata of life. We're all seeking a good quality of life. And each of us will have their own individualized view of what that means to us and where to prioritize different things. Some people might prioritize social inclusion more than they prioritize financial well-being. So there's a mix of different things within there. Having a focus on improving quality of life is useful when setting outcomes from a social care perspective. And the few measures that have been done on measuring quality of life for people with a learning disability and people without a learning disability show that people with a learning disability have a lower quality of life than the broader population. So being able to address that at an individual and a societal level is important. And Mencap have implemented a tool called the Personal Outcome Scale. It was a tool that was developed in Ghent University in partnership with a local provider there. And it was made using a quality of life model that's been tested and retested in different contexts by Professor Shallock. It developed a standardized process to measure quality of life in these 8 domains. It incorporates 48 questions in each of those 8 quality of life domains, and with a three-point Likert scale for each question. And it asks participants to think about what life has been like over the past 12 months and what could lead to a better quality of life for that person. And we can either do an interview with somebody directly, if they've got capacity and they're willing to do it, or if they lack capacity but still want to do the interview, somebody can answer on their behalf. And generally, when someone's answering on someone's behalf, the quality of those interviews isn't as good, so we get 2 people to do that. And as an idea with the data model, these are the questions within the choice domain. So questions like, do people respect your decision? Always, sometimes, rarely or never, or no answer given. And each of those answers gets given a score, which makes up the scores within the quality of life domains. So we can have the individual domains and an overall domain. So the personal outcome scale itself is both an intervention and a measure. So we are measuring the quality of life for people we support, but also using the interview itself to build support plans and one-page profiles. So in this example, Priya, as part of her personal outcome scale interview, talked about what she wanted to start doing. So we have these sections of start, continue, and stop, which captures qualitative information alongside the quantitative information. And Priya wanted to attend more Indian events and learn about her culture. So that was then built into support plans. So taking to food events, good more Indian food, and watching films. So whilst it is at one point a measure of quality of life, we're also using it to intervene and to build support plans on what people want to do. And we got the funding for the project, possibly the worst time to do field work in services. Obviously, COVID affected everyone in different ways. For this project, we couldn't do face-to-face field work because of visiting restrictions. Did try to shift some of the focus to video, but it just didn't work as a practical way of interviewing people and getting the quality of the interview we needed. And then the impact of COVID on someone's workload, the support staff weren't able to do as many interviews as they'd wanted. The interviewers themselves have to go on a 2-day training course to be able to do this kind of work, and it just became difficult to run those training sessions as well. So what we did do, though, is we could still continue with the data work, and what we were trying to do is build an analytics platform. So we could have approached this piece of work by taking individual data sets and analyzing to find factors associated with quality of life. Does living in a certain setting or a certain place make a difference, or turnover of a staff? All those kinds of things. Can we lay them against quality of life scores and see where those associations are? But what we wanted to do is build a platform where we could do that on an ongoing basis in the future. So we've developed a mobile application for collecting interview data, and that sits beside our application called What Matters Most, which is our quality practice framework. And then we can pull in data from different parts of MENCAP as well. So what we're doing is building data pipelines into a cloud platform. And then we are outputting analysis via a piece of software called Databricks, which runs notebooks in the language Python alongside some others, and some visual output in the form of dashboards. So what this allows us to do, and has allowed us to do since the project has died down, is continually experiment. So if we've got a new question, if we want to see what a new factor might affect quality of life, we can do that, and we can do that in a repeatable way. So as an example of some dashboards that we built, this is for the program manager, Ellen, and this looks at the number of interviews that are in the pipeline or have completed. And on the top right, you can see a big flat line. That's obviously the pandemic. So we are picking up again now, perhaps still not as fast as we'd hoped. There's another example of dashboard there, which is breaking down into those individual domains and looking at the spread of scores. So notebooks themselves, I'm a big fan of. So this is where we're doing the more sophisticated analysis in Python. And there's lots of benefits. So we're producing narrative and code next to each other. So the code itself is explained, and we can turn it into a story as we're doing the analysis. It's reproducible. So if I run things once, I can run them again. We're not doing destructive analytics in Excel where you can't repeat those steps. We're doing analytics where we can repeat things. We can collaborate, work with others, and we can use packages and code examples that we find online. So I won't go into the detail of this analysis, but this was an example analysis that we did with the quantitative data. So this was looking at people who were supported in different ways for health conditions. So whether they're supported overall for their health, speech and language therapy, which is often eating, choking risks, epilepsy, diabetes, their medication. And then we can see if being supported with that or not being supported with that will make a difference to someone's overall health score. And we're not looking necessarily for disparities, but we can see if there are disparities there. And what we can see is there is a difference in some places in diabetes and speech and language therapy. But we didn't have a lot of data. What we would prefer to have done is have much more data to be able to look at this. So this is something we'll come back to now we've got more responses through. And interestingly, talking to Ellen, and this is where the rapid experimentation platform really works well, is she thought an interesting approach would be to look at the health quality of life domain versus the social inclusion quality of life domain. So does having health supports affect your ability to be part of your community? And we can do that by changing this analysis here with a couple of lines of code. So the ability to do that is really quite a big benefit for us. What we did have, though, is lots of text. So this is an out-of-date slide now with the 369 conversations. But we'd just been joined by an analyst called Gillian, who'd done a lot of text analytics work as part of her master's. And we were able to use the data that was in there to pull out themes. So when people are talking about what they want to start and stop doing, we can use NLP techniques, that's natural language processing, to take that corpus and start to pull out themes. So this looks like just a word cloud. There's a lot of thinking going on behind it. So what we've done is clean up that data, that text, automatically using the code and using the Python notebooks, and then done what's called parts of speech tagging. So for the question, what would you like to start learning? Just pull out the nouns. And it gives us an idea of what's in there. So obviously it's a word cloud there. What we see, and this might be an effect of the pandemic, is there's themes around digital technology. So people wanted to learn computers and phones and the internet, whether this was a byproduct of lockdowns, but also around cooking, baking, and eating. These are people want to learn around these things. And that allows us to start thinking about things and feeding this into other parts of the organization, saying, okay, well, this is what people are saying around access to technology, and tablets and phones. This is what people are saying around cookery. Can we prepare better information or suggest support workers resources that they can use with people? And to talk about the impacts of what we got, we've got a solid analytical platform now that we can use to analyze personal outcome scale data alongside other contextual data. The platform is being used for other projects that will make a difference to people with learning disability in the UK. And as a team, we've now all upskilled and we're able to approach things in a different way. So it's a really successful project from our perspective. And that is me.
Thank you so much, Owen. I'm sort of already an open source acolyte, so I don't need winning over at all. But it's really, really great to hear you talk so well about exactly the kinds of opportunities that working, with notebooks can bring. And of course, so great to really get to understand how data can be used, not just at a sort of individual level to understand how to improve care for people, but also perhaps at a more population level to understand trends as well. So thank you so much. I'd like to welcome to the stage now Brent Council, who's going to talk about their project.
Hi everyone, my name's Joanne Starkey. I'm the programme lead for London ADAS, which is the Association of Directors of Adult Social Services. And I'm here with a project partner, Miri Adekoya, who is from Barnet Council and also NHS North Central London. So the project we worked on is described in the slide. It was called Strengthening Social Care Analytics. and it was about sharing adult social care workforce data across London to support decision making. So this presentation will just cover three main things. So what problems were we trying to address? What was our approach, and what were the impacts? So if we could go to the next slide, this tries to describe what problem we were trying to address. Just for context, London is made up of 32 boroughs plus the City of London. The adult social care workforce in London is over 200,000 people. And the adult social care workforce data set, as you may be aware, is a service that's provided by Skills for Care. It's completed by all local authorities, and all social care providers are encouraged to complete it. And it provides a really rich insight on staffing levels in terms of recruitment, retention, training, learning and development, equalities monitoring, etc. So with this project, one of the things we were trying to do is tackle a low response rate to the Skills for Care adult social care workforce data set in London. So in February of this year, for example, the response rate was around 35% in London, compared to a national average of around 49%. Insights from the data set were not necessarily being maximised by London local authorities and key stakeholders, partly as a result of the lower response rate and partly due to limitations in data sharing. I've added there that there can be limited capacity within the system to carry out analysis that links workforce insights with other key data sets. So that's one of the things we wanted to address through this project. And that feedback is that London has more cross-borough activity than other England regions. We've got a very fluid care market. And this often means that local authorities want to be able to view data in different ways. So, for example, in neighbouring authorities. And the fluidity, as I mentioned, of the markets compared to elsewhere can be a barrier to data collection, reporting and analysis. So our aim was to develop and share adult social care workforce data across London to support operational and strategic decision making. If we could go to the next slide, I'm going to hand it over to Mui to cover what our approach has been in this project. Thank you.
Thank you, Joanne, and afternoon all. Apologies you won't be able to see me on screen. So, what was our approach? As you can imagine, because we had 32 boroughs in London, we had to really think carefully about how we would garner the information and prioritise what we wanted to do and how we would take it. So planning, engagement and collaboration was a key thing. We decided that we'd use a really good, robust project management approach because we thought that from a programme perspective, what we needed to do is have the ability to actually agree things, test them, and if they weren't really suitable for what we wanted to do, roll back and start again, but do that in a really progressive way. So we took a sprint approach. Obviously, we had a detailed program of engagement and collaboration to ensure that everyone was coming along with us. This involved making sure that we could bring providers and commissioners and contract leads with us. In the early stages of the project, this involved setting up a robust governance structure, through a bi-monthly adult social care market insight board, which was chaired by one of our ADAS. And I must say, if I'm going to say anything, if you're trying to work across a number of areas or a number of providers or commissioners, always make sure you have senior management. So this included, the board included members from London ADAS, London local authorities, Skills for Care, providers and NHS England and Improvement London. Service user engagement and collaboration was sought via the local providers, who subsequently fed back via forums and planned workshops. This worked a treat. The project was driven forward in the interim through weekly catch-up meetings between core members. That, I say, because you can imagine trying to get all the core members together, but we managed it. I think when you've got a passion and everyone is invested, you can make it work. As the project progressed, activities included a series of meetings with single points of contact, and this is something, I'm not sure whether people have it. We found out that the best thing to do when we're trying to work with providers was create a role within each of the 32 boroughs and give a nominated person the ownership of liaising with the providers. And for us, we call that single points of contact. in the local authorities. And the series of meetings, webinars, were also led by the SPOC, as we refer to them, and we had lead providers who were also keen on making sure that they were rallying and engaging with their fellow colleagues. The project was more effective as a result of the insights generated from these conversations. These activities had strengthened joint working overall, as described later in our presentation. Now, introducing a new system for data sharing in relation to adult social care workforce status. We agreed early on and introduced new options whereby providers can either opt in or out. And I think that is one of the best things we actually ever did. The preference for, so the opt-in and opt-out was around whether they preferred their data to be shared or not shared with others. We went with, if you didn't want your data shared, that was fine. If you wanted it shared, again, you could have access to others. So I think that then gave providers the confidence that whatever data they supplied to us, we would use it as they needed it to be. We went through a full iterative design process following DDS standards, including design content and user research to create new data sharing permissions in our adult social care workforce data set. We built and deployed the new data sharing permissions functionality for manual and bulk uploads. And this was what for myself, I felt that was one of the major coups that we actually achieved during this project. This new option also enabled us to actually carry out our plans to have in-depth analysis of the data set, which is a boon if you ask me, because before then it was really hard to actually collate information on providers, especially across 32 boroughs. So focus on driving up the response rate to adult social care workforce data. This is such a mouthful, I must say. And so we continued and had a program of communication and engagement, which was carried out, and we continue to actually do that. Can we move to the next slide, please? And apologies, I can't see, so I'm assuming that the slide deck has moved up. So further on, we had agreed reporting arrangements. This was much more trickier because everybody had a view on what they wanted. However, we were able to make changes to existing Skills for Care reporting, and in light of these insights gained through the project, Skills for Care supplied more detailed data to London on a fortnightly basis to enable local authority staff to focus on their engagement work. This really works out for us in Barnet, for example. We have a care quality team. They were really grateful for these insights that we can now share with them. Across London, we agreed a system where London School of Economics would also support us with analysing and assessing some of those data. So we now have data sharing agreements in place with them. The second bullet point is use insights from reports and analysis. So yes, that is a very interesting one. I think we have used the insights gained from the bigger response rates on the data set in strategic work. I can assure you that as a care homes program lead, the insights we receive from the data from that perspective has been used locally to form our approach to digital program work and enhanced health and care work as well from a health perspective. At a London level, London ADAS has used the insights to develop a draft adult social care workforce strategy. At a sub-regional level, insights are being used to inform and develop the new social care academy, as well as informing joint and healthcare workforce plans. And at a borough level, I've just described what we've used it for locally. Joanne, I think the next slide is for yours, so I'm going to hand back to you.
Thanks, Mary. Yeah, so just to wrap up, in terms of the impacts that we've seen as a result of this project, so as it mentions there, we've made improvements to the adult social care workforce data set, and a data sharing mechanism is in place. And as of 23rd of October last week, 458 providers in London had agreed for their data to be shared, and the same mechanism to share data has been introduced nationally. Secondly, we've seen an increased response rate to the adult social care workforce data set, and therefore we have improved insights. So we have moved from a response rate of 35.2% in February to a response rate of 42.9% as of last week. So we're not there yet, but we are continuing to narrow the gap between London and the national average. So that's meant that the skills for care analysis on the adult social care sector and London workforce is more meaningful and better used. So, for example, in the most recent analysis on the London workforce, which Skills for Care published a couple of weeks ago, it shows an increase in the vacancy rate and provides evidence that recruitment and retention pressures in adult social care have worsened rather than improved, which therefore creates an evidence base to prioritise taking effective action in this area. It also mentions there that we have further embedded the adult social care workforce data set in adult social care. So it definitely feels like more of a core part of the London ADAS regional programme. And the feedback we've received, including, as Miri mentioned, is that it's more of a core part of the work being carried out at a local authority level too. Next slide, please, which is the final one. So we feel that this project has set the groundwork for further in-depth data analytics to be carried out in partnership with the London School of Economics. So LSE plan on carrying out some econometric analysis on the relationship between workforce characteristics of providers and quality going forwards. And we're really excited about the analysis and the work on that. As Miri has mentioned, the project has strengthened joint working, definitely between Skills for Care and London ADAS. Indeed, as a legacy of this project, we've recently established a new workforce data group that's being led by Skills for Care, supported by London ADAS. And it's that group that's going to continue the work of this project. And then finally, I would say that the work has contributed to a safer and more resilient workforce. So as mentioned, we have a London-wide adult social care workforce strategy, the contents of which has been driven by the insights gathered through the adult social care workforce data set. That's made up of 4 core priorities, including around improving recruitment and retention, supporting the workforce, reducing structural inequality, and developing how we work. And the insights through the workforce data are informing the delivery of that strategy. That includes the development of social care academies in each of the 5 London sub-regions that have a focus on staff learning and development. It includes local workforce planning at a borough, sub-regional and London-wide level. And finally, as I mentioned, planned LSE analysis reports, which in turn will enable holistic analysis and informed decision-making on our workforce. So that's it from me. Thank you very much.
And if we could have the next presentation, please. This is going to be Torbay Council.
Good afternoon, everybody. I'm John Bryant. I'm Head of Strategy and Development down in Torbay. And our project was about addressing one of those little threads that we pulled and then were staggered by the answer. I think one of the first things to say was the title that we started off with was Strengthening Data Analytics and Changing Hearts and Minds. But what became clear at an early stage is when we started sharing the data that we're about to show you. In listening to the feedback from our colleagues and our care providers, they were really very focused on the greener care element to this. And part of our learning was that flexibility to hear and be responsive. And they actually determined to change the title of our work to the Greener Care Collaborative. So So the idea that we wanted to work with was how could we release time to care and time to be more caring, and that was very much in respect of caring for the person that had assessed needs in adult social care, but caring for themselves and their colleagues. So we wanted to talk about the care unit and how that can best be put together so that there is well-being for all. That well-being features in the 5 aims of population health management. And the endeavour there was our triplet, which was about better care for clients and patients, better care of staff, and better capacity and well-being for all. And that was the approach that we took and put in front of our colleagues to discuss, and they responded admirably. The social care analytics that this programme enabled us to investigate was a sense that we had that in domiciliary care, this is where people are going in to support and care for people in their own homes, that we had more than one provider covering an area. Torbay is a series of 3 towns, Torbay, Paignton and Brixham, and it's a 75-mile perimeter area. That's all the way around is 75 miles. What we found was that in those slightly darker, sort of magenta coloured areas, which, as you can imagine, are very small, we had up to 11 providers providing care in that one area. The slightly orangey ones are 10 providers providing care in that area. And there was obviously a mix of that where there were some significant providers in terms of an area. Some were doing a lot of work in that area and we were topping it up with small amounts. And other areas, it was a real complex and complicated position where everybody was doing a little bit. And what that began to look like in terms of the actual numbers was every year, in the way that we commission care and work with our providers, we were requiring them to drive 832,000 miles and absorb 41,000 hours of care time to drive around a 75-mile perimeter area. Created 235 tons of carbon. And it was, of course, very evident to everybody that there was a better way of going about things. And this element of well-being, if we could create time and space for people to do the job that they set out to do, to be more compassionate, or to be compassionate and deliver the compassion that they wanted to, and care for each other as well as themselves, then there were evidently good ways to operate. One of the key elements for us was an evident inequality in the system, which was at one of the less well-paid care and profession functions within our health and care system. It's almost, certainly in the area that we work in, Torbay, it's almost essential that you have a car. And to that end, we were then positioning ourselves evidently as a system that required possibly a 2-car family. We could only work in social care if you've got 2 cars, or if you have a car at all and can afford to run it these days. So those that wanted to be able to care but didn't have access to a vehicle or didn't drive were being excluded. Whereas if we looked at how we could better utilise our tools to gather the care, put it in the right place and create neighbourhoods, we could offer care opportunities to a range of folk that would prefer to walk, and even those that can drive would prefer to walk because of costs, etc. We were focused on the generative relationships that one could build, and it builds on something that was said in a number of the other presentations, this element of being able to share the data, gather insights from those seeing it, as well as insights from the data. And one of the key elements for us was this openness and transparency. Where could we position this so that providers felt comfortable and confident enough to actually share their data? That takes work. There needs to be a level of trust built, and we were on foundations that we had laid down for maybe the last 4 or 5 years to be able to do that, and to get the data extraction, which was not only around the sort of generative relationship side of things, but it was a recognition that we got from this project that some people are very good at care. It doesn't necessarily mean they're good at IT. And this program enabled us then to bring in external IT folk to be able to support that and then get the data extraction from them without burdening the provider, so they could do what they needed to do whilst contributing to this work. We took a sequential approach, which was to give them insights into their own data and then into the collective data. And they were able to build on that. And then the learning with the experts for us, there was a recognition as to bringing in people that were outside of our own industry, and we engaged with people that had done work for some of the big telecoms companies, Virgin and BT, as well as Tesco. And then those with experience in the market, but outside of the UK. So we wanted to gather learning that was beyond our own shores and our own sectors to see what that offered us and increase the depth and breadth of our own toolbox. And there's some lovely stories to tell in respect of what difference this made, even to the extent of resilience that was developed by folk and for folk, just because they had the time to walk between clients and decompress and listen to music. And that might seem quite small in the grand scheme of things, but in terms of somebody's well-being and their ability to deliver great care, it was one of the outstanding stories that we heard of somebody just feeding that back very naturally in a conversation with their care providers, that their role and in fact their overall life had been enhanced just by being able to work in a smaller area, do the job that they wanted to do, and have this opportunity to listen to music in between care providers. And I think is that element that we share, and we're about to show in a macro way with what Mark's about to share, as well as in that micro way, which is actually where we all end up, that patient, person, client-centered delivery. So Mark, if I might hand over to you in terms of some of the things that we did and found.
Yes, thank you, John. Yes, so my name is Mark Rosser-Smith. I work for a Finnish company, so this is the International Connection. I lived in Finland for many years. And the company has its roots in logistics, planning and optimization, but we've been working with home care commissioners and providers in Europe now for over 10 years, because back then we recognized that delivering home care is a logistics problem. The right person has to be in the right place at the right time. So now we've conducted over 70 home care projects around, mostly in Finland, and then some in Benelux and Sweden, and now the UK. So on John's previous slide, it mentioned big data, and what we do is we think of big data is where you take data and you can analyze that data and see what happened in the past. And what we do is what we sometimes refer to as big computing, because we take data and then we can model alternative ways of doing things. And of course, when you analyze the past, you can't go back and change that, but you can model alternative ways of doing things in the future, and then that supports decision making. But this slide shows some of the care workers' routes around the Torbay area. So the first on the left just shows the larger area and care worker routes from one provider and how they travel quite large distances. And then the map on the right is a closer up view of the Torquay area, and this is the routes of care workers from just two providers from one particular day. And what you can see is these two providers are crisscrossing over each other all over the place, which of course is very inefficient. It means people are traveling much further than they would have to, and it makes it more difficult to create local care areas. So so it's more difficult for people to walk between their service users and listen to music on the way. It really means that people start to need a car and travel further. And on the map here, we're showing routes as the crow flies, because it's clearer that way, but we do actually calculate distances and so on according to the road lines. And John mentioned the amount of travelling in the Torbay area on an annual basis, and achieving a fairly modest saving of 12% would represent a saving of almost 100,000 miles and a reduction of 28 tons of carbon, and freeing up around 5,000 hours to care. So what we're doing is we've received data from 2 providers. We're waiting to receive data from at least one more, and then we'll start to model alternative approaches, and then providers can then see the benefit if they would somehow cooperate, and then based on that enable them to reduce mileage and give care workers more localized routes. So should we go to the next slide, John? Yes, thank you. So when thinking of increasing capacity or freeing up time to care, mileage is of course one element of that, but also how the load is distributed plays a very important role. And from our work in other countries, we've seen that, of course, home care has a reputation for being quite peaky in nature. You have a peak in demand in the morning, and then you have other peaks for lunch and tea and bed. So this was one of the first things we saw when we started working with home care several years ago, or over 10 years ago in Finland. And what you can see on the graph at the bottom of the page is the load profile from a provider in Torquay. And the graph shows 2 things. So the lower line shows how many visits are planned and plans to happen at the same time. And the upper dark line shows how many care workers there are who have started their first visit but not finished their last visit of the day. So what you can see is that the load ramps up in the morning, and then you have a peak around 9:30 to 10 o'clock, and then the load tapers off, and there's a lot of unused capacity later in the day. And then the load is much lower in the afternoon and evening than in the mornings around. So the load in the evening is around a third of what it is in the morning. And what we've seen elsewhere is that some of the peakiness in the loads, particularly the morning peak, is due to organizational habit rather than actual care needs. So if it's possible to move any tasks away from the morning peak and deliver those later in the day, that frees up time in the morning peak to be able to take care of more people. So that's the basic principle behind that. And you notice that the peaks are much narrower than the troughs, so you don't actually need to do much or move many tasks away from the peak times to free up time to be able to take care of other people who do need care during the peak time. But it should always be based on care need. So we're also now looking at the care plans and how we can better utilize the capacity across the day. And when we look at these types of load profiles from Finland, for example, they're much less peaky. They're much more leveled than in the UK. So this is a very important thing to consider. And what this peakiness in the load profile also means is that the care workers have very fragmented work patterns and poor pay. So you have people who are working in the morning peak, and then after 10 o'clock they don't have much to do. And as care workers, they're paid for contact time only in most cases in the UK. This means that you have a large number of care workers who are fairly poorly utilised across the day, and as a result, they also have poor pay. So it's going to be very good to show in the UK how we can utilise some of this unused capacity during the day. So just some notes here, it's very important to minimise not just the number of visits during the morning peaks, but also the length of those visits, and that could mean moving some tasks from some long visits and delivering those later in the day, so that you're not reducing the amount of service time people get, but you're maybe looking at delivering some non-time essential tasks later in the day. Okay, and this I think is saying the same thing but different colours. So John, did you have?
So just in terms of time needed to wrap up, number of impacts was around inequalities, just recognising the importance of the Health and Social Care Act to enable things. But certainly what we identified through this work was the level of interest that came from a whole host of different people to catalyse around this. And the work enabled us to secure substantial funding towards our Kit for Care project, which has enabled us to develop the primary and social care interface, because people could see where the capacity was coming from to enable that to happen. So yeah, it's been a great journey to date. Some way still to go, but huge thanks to the support that we've had from the Health Foundation, SQW, and everybody else to enable us to get here.
Thank you, John. The Torbay project and also the Brent Council project there, I think both really go to show how important it is to have really strong collaborations across the patch to kind of get those projects really up and running in an impactful and effective way. So I think I will just touch on the Mana Community project, who, as I said earlier, they're not able to be here today, but I will quickly run through some of the work that they had done. And just as a reminder, audience members, please do add any questions that you might have for each of the project leads into the question box. We'll be happy to answer them in just a moment. But first, let me talk to you about Mana Community. So they were looking to develop data analytics to improve how social care is monitored and understood for those with the worst outcomes. So if you remember way back at the beginning, I said some of those priorities that we were hoping to address through the funding programme. One of them was really listening to people who experienced the worst outcomes and reflect some of their lived experiences. And that's exactly what Mana Community did. So they felt that the problem that they were addressing was that there's not enough work to understand the experiences of people receiving care, but also there's a sort of a learning gap where work in the space just isn't always shared effectively amongst organisations. So they hoped to create a thorough, actionable piece of analytics research to understand the experiences of people in receipt of care, particularly those with complex mental and emotional needs. Right at the beginning of the project, they sat down with people from across their community to really think of who was experiencing the worst outcomes, and that's the cohort of people that they wanted to begin with. And what they did was to build a shareable, anonymized data collection tool with text mining analytics underpinning it that allows you to input natural language. So similarly to Owen's project, so that's kind of feedback on the service. And through using analysis, then produced key themes for improvement or for learning. And they worked to develop that tool with a local analytics consultancy. So the project collected and analysed feedback data to understand how care was reaching that group of adults with complex mental and emotional needs locally across where they're based in the west of England. And as I said, the first step really was that co-production element of engaging with partners and people in their community to define those terms. They produced a shareable data set to facilitate adoption of this method elsewhere, but they didn't just produce that data set. they produced a learning guide as well with real world applicability in mind. So they aimed to ensure that that report meant that the capability and capacity for better use of data was built across other regional care services, and that high quality insights were facilitated, and that there was a real genuine inclusivity for all stakeholders being practiced. They, in the end, weren't able to collect as much feedback as they hoped for, again, perhaps reflecting some of the challenges that have faced other projects, simply because it's difficult to be in the same room as people, and that's kind of those are the meaningful conversations that you wanted to have, but the pandemic sort of scuppered. But they did get enough to develop the tool and to really engage meaningfully with the providers, the commissioners, other people giving and receiving care. You can find this work on their website, and I'll post both the research and learning reports in the community of practice too. So if you go to the community of practice, you'll be able to find that. I think we'll move on to the panel discussion now, where I have a few questions already kind of lined up for some of our project leads and their partners that they were undertaking their projects with. So if you could come to the stage, and we'll start discussing some of these thorny questions. I might come to some of our provider organizations. What's your sense of what providers need more of to use data in social care better?
I think there's a skills gap that we need to address for some of the people that want to use data. So our kind of data strategy currently, it's, there's several prongs of it. We need to centralize the data that we have and understand it. It needs to be cataloged. It needs to be governed. We need to ensure it's data quality. But also then we need to skill up colleagues who are all on different journeys and different paths and different sort of how far down they are and how confident they are at using data. We don't always, I'd say, employ people for their use of data. We're employing people on their care skills. So, that's fine that people go on that journey, but definitely a skills gap.
I agree, and I think, well, from having seen some of the projects, I also think that it was really welcome to see in the data strategy that recognition that there was investment needed to really skill up people in social care, people working in social care on kind of digital and data skills. I'm not sure how far that will go for analytic skills, but perhaps we'll see. What about our commissioning colleagues? What kind of things do you think we need more of for commissioners to use data better in social care?
My view on that, Ellen, would be the challenge to ourselves that reflects the providers, which is, what are you going to do with it? What difference is it going to make? What decision is it going to drive, and who's making the decision? And I think that becomes sort of the really acid test questions for us. And at the point that people begin to have a way, and certainly with the work that Satalia and Procomp have provided the illustrations for us, it enabled people that naturally maybe don't work well with the tables to see something and then shape it. Because, as I say, for us, it was, well, I can see the purpose. I can see where this is going now, even to the extent that they determined to change the title of what we were doing. And whilst in some ways some might say, well, it's just a little bit of narrative, John, in terms of ownership and where they wanted to take it, it was really significant. So for us as commissioners, to be able to position something that gets ownership, develops a level of understanding and a level of challenge to us so that it informs our thinking and our facilitation, is really important to give people the tools and the ability to challenge us, for them to own it, to get the right decision for us all.
Thank you, John. I think what comes through in the evaluation is some of those themes again. So I'm sure that Jane and Lauren will kind of speak to us about that in just a moment after the break. I wonder, the kind of question to all of you, what kinds of problems could better use of data in social care solve, sort of apart from the ones that you've been addressing? What other problems are there that we could kind of, address with data?
Well, I'm very happy to go unless somebody else wants to chip in.
I have one.
Go for it, Emma.
One of the things that we started to notice, but is really, really hard to prove, is that when you start receiving care and support from somebody, from just 2 or 3 people regularly who you've chosen, who you know, the health outcomes are almost miraculous in some cases. So the ability of much more nuanced kind of data collection tools to show the kind of the preventative benefits of doing something like that, and then also showing obviously benefits, the knock-on benefits to NHS colleagues, I think would be transformative. Yeah, we've seen people go from being on the fast track, which is what they call it in Calderdale, when you get access to more commissioning because you're close to the end of your life, then have their funding pulled because they're doing so well. But this is really all down to some at the end of the day, very simple formulas. But that stuff is very difficult to prove. It's very hard to measure.
Thank you, Emma. And I guess a lot of that comes through people being able to tell their stories as well, doesn't it? John, you were just about to come in.
I just really endorse what Emma was saying in that space. One of the challenges that social care has is certainly around the likes of workforce, where our NHS colleagues have their electronic staff record and ESR. It's that combined data set. And because of the way that as a centralized system, they pull all sorts of data together and they require this type of reporting nationally. At the point that social care comes to the table and says, well, we've got a lot to offer. It's, well, difficult to treat you as an equal partner because you don't have a rich set of data. Plus or minus, the NHS's could be improved, which it would recognise for itself. It's still way ahead of what we're offering. And I think for us, the ability to seize the opportunity in social care to develop both the volume and the quality of the data. And again, it comes back to, well, tell me the why, show me the vision. But then you hear narratives and stories like Emma shares. The moment that we can do that, I think it will really move us into the space that's necessary for integrated care systems to say good quality data, the volume is right, and we can make significant decisions, which is around shifting activities, capacity, costs to where it really counts, which frankly is around upstream social care work.
I was at a launch of a report on social care data a few years back. It's been pre-pandemic. And there was a senior government statistician, and he was presenting on social care data. So he said, out of any sector, social care has the worst data. And I've worked across every sector from private to public to commercial. The paucity in what you have for national statistics is shocking.
I think that was one of the things that struck us when we were looking to, in the wake of the pandemic, when we set up the funding programme, was we could see that there was a huge amount of work and effort, investment into stepping up support for the NHS, which was absolutely right. But I think we could see that we just didn't know what was happening in social care as well. We don't have those same kinds of data sets. I think if we'd have seen what was happening in social care at that time, at that sort of real time level, we would have been able to kind of action some of that intelligence much more quickly. And I think that's what we need. And I think it will be really interesting to hear from Raj later about how the social care data strategy will kind of achieve some of that vision. So another question here. What has most surprised you or has been the key point of learning for you from your use of data analytics in the social care? Who wants to jump in on that one? John.
For me, Ellen, it's some work we might think about on our systems to enable us to move at pace where we're seeking to push boundaries and innovate. And it's a delicate truth that we should be incredibly proud of the transparency that we have within our democratic systems and our statutory agencies. And it's just one of those navigation points that we might consider in terms of how do I get the right supplier, the right supporter, the right people in the room, pay them to do the job in a way that enables us to continue to create momentum and move at pace. And so for us, part of the learning was, with some of the things that we were seeking to do, it wasn't necessarily about the analytics. This was a learning point from the analytics program, was how do we create an environment where the structures that we were using supported the innovation that we were seeking and kept people engaged. Because that was quite difficult to employ people, contract people in resource tight. There was little headroom. We needed to bring additional people in to test and work with people that we weren't familiar with, where we reached out outside of our system to try and specify that and procure that. When we were walking into territories, we didn't know the language, we knew where we wanted to go, etc. There's something around that experimentation, PDSA cycle, trusting the gut to some degree to find partners to work with. So that's something, given that it's a much broader, we're in an innovative, integrating world. What does that look like for us to take good decisions, be accountable for the public pound, be accountable for our grant funding, but at the same time to work in ways that maintain enthusiasm, momentum and energy and get good results?
I can tell you the most surprising thing for me that emerged from our project, which is that every single person we spoke to, including the people who were perceived as having power, felt powerless to be able to affect change and to improve the lot of social care. There was a very strong perception from commissioners all the way down through the chain that the people who were in power were A, not them, B, not accessible, C, not going to do anything about it anytime soon. And that sense of powerlessness, I think, and has been supported, I think, by our work and the work of our projects, is strongly reinforced by the lack of available data in social care. One of the ones that has not been, the stories that is not told in social care is about the power of investment and its relationship to economic wealth. Simply by, it's a very simple question, how many family members are able to go back to work because of reliable, consistent, really high quality care that their family member is receiving? How many jobs have been maintained? How much has the UK's productivity been protected by strong investment in social care? Commissioners can't make those arguments. The data is not there. No one is asking those questions. And without that, it's just business as usual.
I think we're about to break into our. Oh, Simon, were you about to come in very briefly?
Oh, I was about to add to what Emma said. If I've got a couple of seconds, yeah, that was you put it better than I could have done. But that was the point that I came straight to my mind, was that sense of powerlessness from everyone, and also we've got a transparency project and we are publishing data, but what a lot of people were asking for was the transparency of the process. They don't know how decisions are made that affect their lives, and publishing the data that we have done, at the best, it will be a proxy for that, and that's a leap of faith. Having sort of next steps that we can think of would be along the lines of trying to define a way of getting people to define and publish how they make decisions in the general sense, not about individual decisions that they have made, but just about the processes that they go through. And because that doesn't exist, there was a notion of people having a guide, an intermediary to help them when they first enter the social care system. And that came out in more than one of the workshops, as I recall, and independently came out in more than one of the workshops.
Yeah, I think that sense of powerlessness and the other kind of dynamics that are coming through in your project, I think just underlines the importance of having a community like the Future Care Capital Community of Practice that welcomes in anybody and everybody that wants to know anything about social care, and that provides a forum for people to have these kinds of discussions and kind of come together as a collective that hopefully will kind of create some power of its own. And on that, I'm going to bring us to a break. We'll come back at 25 to, so we've got 7 minutes. And after the break, we'll hear from SQW. So looking forward to seeing you after the break, just in a few minutes. Thank you, everyone. Welcome back, everyone. We have 3 more speakers this afternoon. So we have SQW, who evaluated our Strengthening Social Care programme and who have some reflections and recommendations for us. Then we'll hear from Raj Marley at DHSC, who will talk about the social care data strategy vision. And finally, from Peter Bloomfield, who will talk about what Future Care Capital is doing in this space as well. So without further ado, I'd like to welcome Lauren and Jane from SQW.
Hi everybody, I'm Lauren Roberts. I'm the director at SQW, and I'm joined today by my colleague Jane Meager, who is a managing consultant at SQW, and Jane was our project manager for this particular evaluation. So we're going to talk to you a little bit today about the findings from our evaluation and the recommendations that we generated. So Jane, if you could move forward onto the next slide, please. So we will talk to you briefly about who we are, what we were asked to do, what we did, what we found out, particularly focusing on the outcomes generated, because you've already heard today some really interesting insights from each of the projects about what they did. And we'll also talk about the recommendations that we've developed based on the findings at both programme level and at project level. So next slide. In terms of who we are a research and evaluation consultancy. There are about 50 of us spread across the country. We work in a range of different areas which are listed on the right-hand side of the slide. And in terms of this particular evaluation, obviously social care, skills and innovation, in terms of those themes, were all really, really pertinent and were things that we explored. So we were commissioned by the Health Foundation in July last year to evaluate the programme, and that involved working in depth with the 5 funded projects, also those involved at programme level, and trying to understand exactly what happened to generate rich findings. So if we move forward onto the next slide. It was a qualitative process evaluation that we were commissioned to carry out, and we aimed to explore how the Health Foundation's funding supported the funded projects to improve the use of data analytics within social care. So we worked through from July last year through to August this year to develop those findings. And we did this over a 3-staged process. So the first stage was a really in-depth scoping phase, essentially to find out a little bit about the project plans, who was involved in the projects, where they got to by that point, and also the programme context more broadly. That helped to inform our evaluation plan and the tools that we developed for the interim and the final phases of the study. Now, each of those 2 second phases, we did 3 main types of activities. One was a series of observations of meetings and activities. The second was a review of documentation that was provided to us that was developed either at project level or at programme level. And the third was a series of interviews and small group discussions with those involved either at project level or at programme level. So we spoke to the project leads, we spoke to the partners that they were working with, and we also spoke to a series of end users who were involved in the projects. And those end users were either people in receipt of care, caregivers, or organisations that are involved in providing care. So we brought all of this data together. At the interim stage, we produced an interim report, and we ran a workshop with the projects and the Health Foundation, really to test out the findings and reflect on what they meant. And then we produced a final report which sets out the findings in full. There's a lot in there. We won't get close to touching on half of the content today, but we brought all the findings together and presented some examples from each of the funded projects. And obviously today is a chance to reflect on the key findings that we've developed. And I just want to say before we get into the findings, thank you so much to everybody who has contributed to the study, either by talking to us or providing documentation and sharing insights. We couldn't have done it without everybody contributing and talking to us. So I'll hand over to Jane now to talk you through what we found out.
Thanks, Lauren. So we heard from the projects earlier before the break about the outcomes they achieved, but we wanted to reflect on this at a programme level. So from the outset, the programme aimed to support projects to achieve outcomes in 3 key areas. So developing new and improved skills, enhancing culture and collaboration, and delivering better care. So just delving into these 3 outcomes in turn. So our evaluation found that the programme had supported skills development, which included the development of new and improved data analytics skills, but also broader skills. So for example, project management, stakeholder engagement, research. And in turn, this led to subsequent outcomes. So for example, organisations increasing their own organisational capabilities and being able to use key skills that they'd learned to improve their own processes and systems. And individuals also reported increased knowledge and understanding of data and data analytics, which in some cases had led to new opportunities, as shown in this quote from a project partner, who have been able to use new knowledge to improve their business offer. And the programme also supported improvements in collaboration, as we heard a lot about earlier, with interviewees describing new and improved relationships and partnerships at varying levels. So within their own organisation, as shown in this quote, with other organisations within the social care sector, and then in some cases with organisations outside of the sector as well. And organisations from outside of the sector who partnered to deliver these projects, they often reflected that they'd improved their knowledge, their understanding of the sector, and were therefore more likely to collaborate with organisations within the sector in future. The programme also encouraged collaboration and co-production with those providing care and those in receipt of care, which led to increased buy-in to the projects and data analytics more generally. And for some projects, bringing provider organisations or service users together was said to create, I think as we heard before, a sense of community and really enhanced relationships. We also heard some examples of projects experiencing or starting to project organisations to experience a cultural shift. So in regards to the use and value of data and data analytics, so for example, one interviewee said that the project had open eyes in their organisation to the value of data in improving social care. That said, interviewees also noted that cultural shifts would take time to be fully realised, and in some cases relied on projects or learning being sustained post-programme. And it was a similar story with providing better care. So while really this was a longer term objective of the programme, which we weren't fully able to explore in the timescales of the evaluation, there were some examples of changes implemented as a result of projects which had begun to improve care. And while not directly linked to better care, a real valued knock-on effect of the project has been benefits experienced by caregivers and service users who have been involved in the delivery of projects or who have participated in data collection. So this has included improved confidence, improved skills, and the opportunity to reflect on their own experiences of care in safe spaces. So overall, most interviewees said that projects wouldn't have been able to implement what they did without the programme, or at least not to the same scale or time frame, and therefore some of these outcomes might not have been realised. And this was attributed to resource and funding, but also because of the broader support delivered by the Health Foundation, which was described as quite light touch, but also quite consistent, and that seemed to support momentum. However, continuing to achieve outcomes was reported to rely on project sustainability, as I just touched on, or at least ensuring learning or approaches continue to be implemented. So alongside progress towards outcomes, the evaluation also explored programme implementation in terms of the different approaches used by projects and the overall enablers and barriers experienced. And based on this learning, we developed 11 recommendations for projects who might want to deliver similar approaches, and 5 recommendations for the programme overall. So I'm going to talk through our project level recommendations and then pass back over to Lauren to talk through the programme recommendations. So for projects, the first 5 recommendations focused on project management, design and delivery. So the first recommendation is around collaboration to secure the skills to deliver projects. So project leads draw on a wide range of skills to deliver projects, from those within their own organisations, and then also partners within and outside of the sector as well. And bringing together the right skills mix where there were gaps meant that projects broadly had the right skills, the right knowledge, and the right capacity to deliver their project. And this included technical skills around data analytics, but also research skills, service user engagement skills, stakeholder engagement skills, project management skills, a real range. Our second recommendation was to adapt or refine pre-existing approaches where possible. So I think all projects did this, so using existing approaches and adapting or refining them to suit their context. While this can sometimes limit innovation in the context of a year-long project, it allowed for greater progress to be made, as projects didn't have to use lots of resource and time on early stage R&D work. Thirdly, projects should implement a project management approach that's flexible, agile, and responsive. This might seem quite obvious, but came out as a real enabler, particularly in response to unforeseen issues like COVID pressures, data issues, personnel changes, delays in inputs from different partners. Fourth, to develop clear information governance processes from the outset. So some projects saw expert guidance on information governance processes, which was also thought to be an enabler to projects. So for example, seeking legal advice where appropriate, and also communicating this to all partners involved in data collection was considered really important, as well as fully understanding the limitations of partner processes. Projects sometimes had to pivot their methods when this wasn't fully worked through from the outset. And then our fifth recommendation was around implementing strategies to maintain momentum in the event of key personnel changes. So projects often relied on the drive of a key individual to sustain delivery, or individuals to sustain delivery, which worked well if there were no changes, but there were challenges experienced for some projects when people left or were ill. So we recommended that there be clear succession plans in place to mitigate against some of these challenges. Our next set of recommendations are around engagement and comms. So firstly, we recommend engaging with end users. So as Lauren described, we use that term to refer to those in receipt of care or caregivers or provider organisations, depending on the focus of the project, to ensure projects are appropriate, build trust, and achieve buy-in. So this emerged as particularly important for commissioner-led projects, working with providers who are required to share data and give time to the project. And overall, feedback was that engagement needs to be accessible, it needs to be meaningful, and careful consideration needs to be given to supporting the processes involved. So, for example, drawing on existing forums or networks to support co-production, or drawing on experts to engage with seldom heard or priority communities. Linked to this, we also heard from end users themselves that it should be made really clear how they're contributing to projects and how their data will be used, and then subsequently closing the feedback loop by sharing outputs and learning back. Our second recommendation in this set is to establish clear comms processes and strategies from the outset, including communicating key milestones to partners. So overall, strong comms, unsurprisingly, was central to projects that got successful buy-in from partners and strong levels of engagement with the project throughout. So next set of recommendations around data collection. So first, to implement inclusive and accessible data collection processes for service users. So using suitable language and methods to maximise both the quality of data collection and service user experience. And also possibly to work with those delivering care or service users to co-develop and pilot tools for data collection to understand the most appropriate and inclusive ways to collect that data. Next recommendation is around working closely with organisations who are doing the data collection to plan for and limit any data transfer issues involved. So through agreeing expectations around roles, timescales for data collection, the volume of data needing to be collected, and comms strategies. And then finally, we made two recommendations around learning, dissemination, and sustainability. So firstly, it was important to continue to capture and record contextual learning, both throughout and beyond the project, so it can continue to be shared via a community of practice or through developing toolkits or blogs that can be shared with other projects. And then finally, aligning sustainability or dissemination strategies with any policy changes to capitalise on opportunities for reach and potentially show additional value to prospective funders. So I'll just hand over to Laura now to touch on our programme level recommendations.
Thanks, Jane. So the first programme level recommendation on here is aimed at future similar programmes. So this is around providing targeted support and guidance for those looking to form collaborations for this type of project. And this is essentially around helping introductions, because we know how important the partners were in the projects that didn't already work in social care. They were absolutely key in terms of bringing some of the tech know-how, some of the knowledge around how to do the analytics, but linking those up with sector-based partners feels really important for future similar initiatives, because the relationships aren't always established at the outset and people don't know who is out there. The second recommendation on here is around ensuring that project leads and other partners can evidence that they have the capacity to drive the project forward. Now, this is really important. Jane presented a project level recommendation there around maintaining momentum and planning for any turnover, ensuring that there are smooth handovers. That's really important at an individual level, but we think that for future projects or programmes, there's something about looking at organisational resilience and ensuring that that capacity is there where it is most likely to be needed at key points within the project, and where that capacity is required may well vary throughout the project duration. So we think there's a role for the Health Foundation or other similar funders there in understanding that at the outset and having that conversation with those potential projects that they might be funding. Now, the next three recommendations on here apply, we think, for future similar programmes, but also apply particularly to this programme going forward. So the first is around sustaining ad hoc or light touch support to the projects. In terms of what this might look like, it might look like signposting to future funding opportunities. It might be around help with dissemination or linking up projects where there's potential for sharing learning across different projects. But we think the Health Foundation has a role to play in that. You've heard from the projects earlier on, a lot of activity is continuing. It's likely that outcomes will emerge over coming months. And we think it would be great if the Health Foundation can continue to work with those that they've funded to try and understand how they progress and support them as they go forward. So the next recommendation on here is around providing support to disseminate outputs and learning. So I've talked about that a little bit on the previous recommendation, but we think there's something there about sustaining the community of practice too, so that others can learn from the activity that's taking place on this programme, can understand how projects have taken things forward, what's emerging as a result, and also drawing on the Health Foundation's networks and contacts to share that learning a bit more widely. And the final recommendation that we want to present at programme level is around capturing the outcomes of the programme. As I've said, they're not all fully evident. We expect that more will emerge over coming months and even years. So we think there's something there around capturing those in a light touch way. It doesn't need to be overly burdensome, but we think there should be some really nice stories and examples that emerge going forward. And it would be a real shame if they weren't captured. So we will close there. Thank you very much.
Thank you so much, both of you. We certainly have lots of homework to go away and get along with, particularly with my other colleagues across the foundation when we start looking at other funding programmes that could be looking at social care as well. And I hope that the project recommendations are useful for those of you dialing in, looking for other opportunities to begin to look at data analytics in social care. So next up, we have Raj Mali from the Department of Health and Social Care to talk to us about adult social care data.
Thanks, Ellen, and thanks to you and Future Care Capital and the Health Foundation for inviting me to provide an update on what we're doing centrally to support better data in adult social care. My name is Raj Mali and I head up the Social Care Strategy and Data Unit in DHSC. And apologies, my webcam and my screen is broken, so I'm having to use my laptop one. So even though I'm looking slightly not directly at the camera. I'm looking at the screen, and I can see others who are joining. Before I begin, I think it's fair to say that central government has gone through some change in the past few months, most recently last week with a new Secretary of State and supporting Ministers of State. So while what I'm about to talk about today is largely what we have committed to publicly, it's not to sort of prejudge any changes in direction that might come from the new administration. And just to set the context somewhat, and some of the presenters have already talked a little bit about the maturity of social care data, particularly with reference to other sectors, including the NHS. Prior to the pandemic, we had, at a national level, very limited data on adult social care. For example, we had no national source of data from providers on capacity, workforce status, numbers of people in receipt of care, and most data was captured through annual aggregate returns from local authorities. In response to COVID-19, government introduced emergency measures that enabled the collection of new data that has been used by national and local government to respond to emerging risks and issues. And while there are certainly lessons to be learned about the implementation of these emergency measures, particularly around stakeholder buy-in, they have led to a step change in our understanding of how the system works and the sector-wide benefits can accrue from increased access to data. And since then, we've been working together with local authorities and social care providers to deliver several transformative data projects to enable all actors in the system to better use data to support their role in the provision of care. So if I could just ask Taryn to move to the next slide, and thanks in advance to Taryn for putting out the slides for me. Our vision is that users and system actors alike have access to timely, high-quality data to make informed choices about care and support, and for local authorities and care providers to operate effectively to improve care quality. Specifically, we want data collections to be transparent and with a clear rationale for purpose, and for the collections and associated burdens to be proportionate, and where data is collected, for it to be routinely shared back with those who need it. We also want people who use care and support services to know that their information is being used well, so that those supporting them have the full picture of their needs and that they are reassured that their information is being handled with respect for privacy. We have three key principles that are guiding our approach over the next 3 years, which you can see on the right-hand side of the screen. Improving social care data also improves the evidence base for us to be able to support future interventions and central government financing requirements. If I could ask you to move on to the next slide, please, Taryn. So over the next 3 years, just translating that vision into some of the bits of activity that we're currently doing and will embark upon over the next 3 years. And what you see on screen is a continuous loop rather than a linear process. But at a national government level, we've been working through our data requirements. For example, what are our needs to support the implementation and monitoring and evaluation of system reform and our 10-year vision for social care? And what are our requirements to be able to support business as usual surveillance of the sector to understand pressures and risks and to be able to respond accordingly? And through a number of different forums, most recently through co-designing a new care provider data collection, we have been identifying data requirements from different actors in the system. For example, for care providers, providing a mechanism where data is collected once but used many times by multiple organizations would help reduce the duplication of requests and improve the productivity in the provision of care. This has provided us with a really good evidence base to look at whether any of these requirements can be met through national data collections or through new data development projects. And one of the projects that I wanted to briefly touch on in more detail that you'll see on the screen is the LA Client Level Data Project. Here, we're really seeking to move away from collecting aggregate data to more regular person-level data from local authority systems. We see this as a critical enabler to better data flows across the system. It will bring social care collections more in line with NHS person-level collections. And by using the NHS number, it will allow social care data and healthcare data to be able to be accurately and appropriately linked. This will help us to understand how people move between the system so that we can gain better insights into outcomes, which interventions work best, and how local systems and partners work together. The client level data project is piloting in about 43 local authorities at the moment, with a view to adoption across all 152 by April 23. Among other things, it's enabled local actors to better plan, evaluate, and improve local services. So, for example, the project has been used to create bed planning tools based on health and social care patient flow models to explore how the system interacts and the impact of service change from one part to another on usage and outcomes. Others have used the project to create a patient-level population segmentation tool for direct care and health needs assessment, grouping patients into segments and providing routine analytics to shape commissioning plans and provider service integration plans. Outside of the specific data projects, system reform also presents or actually makes it an imperative for us to evolve our monitoring frameworks, such as the Adult Social Care Outcomes Framework, not only to make use of new social care data, but also to build our evidence base, as well as monitor how reform is improving outcomes that matter to people today. We also want to improve the accessibility of the Adult Social Care Outcomes Framework so that people outside of the analytical community can better understand and use the data for their own needs. And finally, there's a package of work underway through the Digitising Social Care programme to support sector digitisation, which is being led by my colleagues in NHS England and Improvement. That will provide the underpinning capability to support better use of data through, among other things, the adoption of digital social care records. We also are about to start a discovery on a project to improve access to and use of data and insights from national data collections. My unit will be outlining all of this in a publication due to be published at the end of this year, but it may be pushed back in what we're terming as the Adult Social Care Data Framework. And it will be published in draft form for engagement before the final form is published in the summer of next year. And just to say that before I started speaking, I joined the call at the end of the project's run through, and it's really encouraging to see the different ways in which data is being used already to generate new insights and ways of working to support those in receipt of care in such a small space of time. So thanks for inviting me, and I'll hand back over to Ellen.
Thanks so much, Raj, and it's really encouraging to hear that the report will be published at the end of this year or perhaps at the beginning of next, and looking forward to doing some consultation work with the wider community and perhaps people on this call as well to kind of begin to look at how that's shaped. Wonderful. Next up, we have Peter from Future Care Capital. Last but certainly not least, Peter.
Hi there. Thanks, Ellen. It's really great to hear all of the insights from everyone today so far. But yeah, as a lot of you will be well aware, the project as a whole is a bit of a collaboration between all the different partners. The Health Foundation obviously is the overall funder and has kind of really given birth to the whole of this initiative. Which has been amazing. Future Care Capital has been involved in running the community of practice for the programme. So that's bringing together lots of the organisations and the analysts and the care sector together. And through that, we've hosted a forum online, which has a discussion board that people have been able to contribute different ideas and suggest different projects and ways forward. We've hosted quite a few different events and published blogs and disseminated findings and best practice from a lot of the projects that you've just heard about. And this has all been enabled by a few different parts of our team and the Health Foundation team. So I just wanted to say a big thank you to everyone who's got the project and the programme overall to this stage. So my colleague Josephine, who's moved on from Future Care Capital, she really helped set this whole initiative up and run the community of practice while all of these projects were happening. Ellen has been amazing. She stayed on top of all of the different strands in a way that I know that I wouldn't have been able to do. So well done, Ellen. I think everyone through this work has really appreciated your attention to detail and your ability to kind of get everyone moving together. Then in the background, there's a lot of work that's happened from Future Care Capital. So Taryn and CJ have put so much into running these events, sorting out logistics, the different marketing material and online information, which ultimately really helps to get the information out there so that the sector as a whole can adopt some of this really good practice. And we've seen through all of the presentations today that from a very kind of early starting point to now, there's been a huge amount of progress, and not just on data availability, but being able to share resources and tooling, and looking into some of the really key matters that are either barriers or hopefully barriers that we're now overcoming in terms of making use of data and keeping the people in the care sector at the center of data analytics, and really acknowledging how personal this data can be, so that when we are using it, we're doing it in the right way and in a way that works for the people that ultimately we want to benefit from the use of the data. Over the summer, Ellen and I have been working on the next steps for the community of practice, and thinking about, okay, well, we've got this really great community and all of this work that's ultimately going to help transform the sector as a whole. And at this stage, it's probably beyond the scope of Future Care Capital and the Health Foundation to be able to do the next steps justice. So part of that work that we've been doing over the summer is starting to find a new home, or at least a place that the community can scale and be taken to the next steps for the sector as a whole. And that's where former colleague Denise has come in as well. She helped to set a bit of a timeline and a structure of how to take the community of practice further, and what it could look like going forward. I'm not going to present all of those details now, but we do have a little bit of an announcement to make that the work is being taken up by the Transformation Directorate and Digital Social Care. So Tommy Henderson-Ray and Katie Thorne, who a lot of you in the audience will be familiar with, have really engaged with the work that we've been doing here, and have really enjoyed how productive the community is and how well engaged the audience is. So they're going to be helping to take on the community going forward and integrating it with some of the wider digital social care initiatives around the country, and bringing together a few different communities to make sure that things aren't fragmented and that things are happening together, and that the onward engagement and growth of the work is successful and joined up. So I think I'll leave it there, and I didn't go through any slides or anything because I know that there's been a lot of presentations today. So I just wanted to say thank you everyone who joined, and thank you everyone who gave a presentation and an update. And lastly, a massive thank you again to Ellen. Your work on this has been incredible. Thank you.
Thank you so much, Peter. That's really kind, and certainly it feels like I can't really do justice to the amount of people who've really put in a huge amount of time and effort into making this whole program a success. And I feel like although perhaps we should have focused on supporting social care data perhaps sooner, I think in terms of the time, now seems like a really interesting and important time for us all to be mobilizing together as a community. Obviously, the policy context has changed so quickly. There's no time like the present. So I would encourage you, if you're not already part of the community of practice, then please do join. There'll be a link right at the end. And I guess just to say that I'll see you there, and thank you for joining today.